All right, good evening. Welcome to today's webinar. I'm Danae Abear. I'm the Healthcare Innovation Supervisor with Well-Ahead. Thanks so much for joining us. Please note that your lines are muted to prevent background noise, but you can enter questions into the Q&A box at any time during the presentation and we'll address those throughout. Today is our fifth webinar of our Telehealth and Practice webinar series presented by Dr. Ted Hudspeth. And today we'll be talking about urgent care and telemedicine. If you weren't able to join the previous sessions, the recordings are available on our website for your convenience. All of the sessions are listed here and the recordings are on our website at walpen.org/telehealth. We'll also have some on-demand sessions in the coming months, so keep an eye out for those. Those will also be on the website. As a reminder, this webinar series is funded in part by the TxLaw Telehealth Resource Center, which is a HRSA-funded program through Texas Tech University, which is designed to provide technical assistance and resources to telehealth programs in both Louisiana and Texas. And TxLaw has partnered with us at Well-Ahead to serve as the support representative for Louisiana providers. And then TxLaw is also part of the National Consortium of Telehealth Resource Centers, and you can access the website telehealthresourcecenters.org to see all of the resources from all the TRCs across the country. And so with that, I will hand off to Dr. Hudspeth.
Well, thank you, everyone. I am excited that we have a fair number of folks on tonight that are registered. We have been building this over some time now. This is number 5, I can't believe, and we are going to actually have 16 in this series ending in June. So stick with us. We hope to be presenting some awesome information to help you figure out how you can implement telemedicine in your practice to be able to help patients, who may have some burdens with getting to your office, both with transportation or time-wise. Everyone is so busy today. So we're hoping to be able to help teach you some of those things, okay? A little bit about me, since so many of you are new to this webinar now. I am actually from Amite, Louisiana, a rural city. And so that is where my heart comes from. When I wanted to start being a physician at 7, it was in the city of Amite. And, I branched out, went to New Orleans, Baton Rouge, and Shreveport for all of my training, Purple and Gold, LSU. And I came back to Tangipahoa Parish, where, we are a rural parish, but I practice with Ochsner, have been there 27 years now. So I have gotten to be one of the old guys there. And I was blessed a couple of years ago by them to be part of their telemedicine project. And it has just been a whirlwind since then. When COVID hit and we were prepared with a telemedicine capability, it was a godsend for our practice. So I hope that you look at all of these webinars and really invest in trying to develop this part of your practice to service your patients. So we want to go through and ask for any questions from the previous sessions if we have any. Danae, do you have any on tap for us?
I don't see any just yet. I'm keeping an eye on the Q&A box over here.
All right, well, if any pop up, you can just let me know and we'll try and answer some of those. So I'm gonna start off saying that care should not start in the emergency room. We all know that, but why does that happen? It probably happens a lot of times because of lack of access. People can't get in or transported to you when you may have an appointment, et cetera. And I have found that with telemedicine, it actually makes some of the appointment times a little easier. I gain back some of my time, and actually I can help more folks. And if you can just do some things to be able to help keep people out of the emergency room, that is really where you prove your value over time to patients. And so in talking about all of this, we're going to talk about urgent care today. This is when people need you the most, and they're making that decision of whether they need to go to the emergency room or whether they need to see, their provider. So we're going to talk about several things here. First of all, I would love to go through some of the statistics on urgent care itself, and then telemedicine statistics itself, because it's just amazing how much this is growing and is going to continue to grow. I'm going to go through some urgent care protocols. These are actually some protocols that have been developed by a friend of mine, Dr. Dr. Nikolic. Asia Nikolic is her name, and she has done a wonderful job of making some protocols to try and help folks know in a telemedicine environment, what to do and which way to triage. So I hope that'll be a help to you. In addition, I'm going to go through the physical exam that I use, and I really look at this document tonight as being more of almost a reference for you. I have a very large presentation here. I'm going to blow through some of this stuff because it's just not amenable to doing a lot of this with me, but it's a reference for you to go back and do some additional study. I have some links to some great videos on doing some telemedicine exams. These are things that you need to kind of go through with some detail and really learn, sit down and take some time to learn. But I've got some great references for you. So I think you'll use this document in the future. We will also go through our urgent care documentation. And then I have one link for you, or one thing to show you as a potential way for you to get your practice listed online for urgent care. Okay, so let's get started here. On the urgent care statistics, in the United States, there are more than 1 billion ambulatory care visits and more than 130 million ER visits every year. And the estimates vary, but the telemedicine is felt to be able to really replace 30 to 50% of all of those visits in the future. Once we get enough people doing that and having enough people understand how to do it, that would really help out on the high cost that we pay for urgent care, because so many people just go directly to the emergency room for their care, which is not where it should start, right? And about 20% of Americans live in rural areas without easy access to primary care or specialty medical services. And you guys are in the trenches in the rural areas. You know this more than anyone else. And only about 1 in 10 physicians actually practice in rural areas in the United States. So that's where the huge need, or why the huge need exists, is because we just don't have enough people out there. The number of urgent care centers that have popped up in the last several years has been pretty phenomenal. This right here just shows you what growth there is in the urgent care market. More people are going to urgent cares for routine care even. So when you look at these numbers, these are businesses that are really thriving right now, and it is expected to grow. The urgent care market size itself right now, it's about a $29 billion market. And that's actually expected to grow by about 3.1% over the next year and continue up from there. Urgent care clinics currently handle 89 million patient visits a year, and that's about 29% of all of the primary care visits out there, and about 15% of all outpatient physician visits. So when you think of that enormity, urgent care is a business that you should be in. It is going to continue growing. And as you see, the competition is stiffening for that. So you may see in your practice that people may start going other places to get their urgent care if you can't supply that. And the fact that telemedicine is growing, that's going to be an area of the market that people are going to derive their care more in the future. Now, I just wanted to point out some things here. This is actually the virtual visit market now, okay, by size and service type. So you can see where we are. We had a huge bump because of COVID in 2020. That's where everyone got introduced to telemedicine pretty much. And you see, we'll probably take a little dip this year, but then it's going to take off from there. It's going to continue growing. And I want you to focus down here on these colors. Like, for instance, look at the urgent care, since we're talking about urgent care right now. In 2027, that light green area is going to be bigger than our entire market of telemedicine right now, okay? And the same is true. Look at the preventative care. Now, just preventative care, that means like your annual physicals and things that most of you do in your practice every single day. that is going to be bigger than the current market of the telemedicine market. Okay. And the other one, that chronic care management. Now, that entails a lot of things, not only your particular visits of chronic care management, but also how patients will be tracked via, external blood pressure cuffs, um, pulse oxes, scales, glucometers, everything you can think of. Systems are being developed and used already to be able to track patients. So that entire market is almost non-existent now. That is going to grow a lot. So let's go through a few telemedicine statistics itself. There was a study that was done where they actually asked 2,000 adults, half of who identified as having chronic illnesses, about their attitudes and preferences towards telemedicine starting in July 2020. Okay. So we have a link here that you can go to see that whole study. But this slide to me says it all. This is the first quarter of 2020. And if you look at week 10 to 11, what happened there? COVID hit. All of a sudden, there was a paradigm shift because of need. Markets changed dramatically because of need, okay? That one event, it probably would have taken us 5 years to get the market and physicians and nurse practitioners to be able to change their way of delivery of care. This happened overnight. I mean, literally. Within my own institution, we went from somewhere around 200 visits via telemedicine in February of 2020 to around 50,000 visits in April of 2020. So you can see what happened here. What these lines are, the black lines, the dotted one is actually the percentage of people going to an emergency room, okay? And the dark black line with the uptick is actually your telemedicine visits. So all of a sudden people changed into this and they saw that it was pretty doggone easy. It also was very effective for them, okay? Patients loved it. It was very convenient. So when you mix all of those things together in a market-driven economy like the United States has, you are going to see a shift in behaviors. And that is why I feel strongly that telemedicine is going to be a place where we need to be for our practices. So for Americans who have participated in a telemedicine visit at least once, you can see in general patients, they have a dramatic increase in the number of people who have done it once since the pandemic. Now that was in July. And then patients with chronic conditions, they really went online. So if you have chronic patients out there, they did it in droves during the pandemic. This is a slide of people who plan to use telemedicine once the pandemic ends. It was 23% of patients. And actually, the people who feel more comfortable using telemedicine since the pandemic, that increased 27%. And comparing telemedicine to in-person visits, they were asked if they feel that telemedicine provides the same or better care. And if you see general patients, there was a 28% difference there. And in patients with chronic illnesses, 53% of people felt that it provided the same or better care. So patient attitudes towards using telemedicine has dramatically shifted since COVID hit. And as far as device of choice, looking at this, patients overwhelmingly prefer to use a cell phone. I think that people connect with everybody through their cell phones. So I think there's just a comfort level there. And as far as tablets and laptops, there really wasn't that big a difference between general patients and patients with chronic conditions. So you can look at this study. There are some other things that you can look at as far as preference of cell phones and telemedicine visits. But I feel strongly that as the telephone market goes, that's going to continue increasing. Everyone's going to have a cell phone that is a smartphone, and they like doing it through there. So I'd encourage you to guide your market towards that type of thing. So Danae has a poll for us. Danae, can you bring that poll up for everyone? So the question is, which urgent care problem do you see most often? A little typo there, but which urgent care problem do you see more often? So if you guys can fill in the blanks there, and we will share all of those later on.
Dr. Hudspeth, while we're paused here for a second, we did have a question pop up in the Q&A. Meta asks, she said she found your Facebook group for providers, and she would like to join, but she's not a provider. She's a quote admin type. So she was wondering if it was possible to open the group to admin types or if there was a separate group for that.
I think that would be wonderful. At this point, I have no members of that group, but we have discussed having a group, and actually through the Well Ahead program. So I don't know where that stands right now, but as if you apply or put your name in and you're interested in making telemedicine better in Louisiana, I think anyone can join that. So give us a little time to be able to move forward with that. All right, so let's click through and we'll go from the poll. All right, I'm going to go through urgent care visit types. Now, I want to be very honest with you guys. When I first started doing this as part of a pilot in 2018, my vision was that I would be seeing a bunch of urgent care through telemedicine. I guess the reason that I did that is because that's pretty much what everyone was doing back then. And I really had not expanded my thought on what telemedicine would be. For those of you who don't know, I have an extremely busy practice. I have about 3,000 patients in my practice. I do that 3 days a week, and then 2 days of my week, I perform EGDs and colonoscopies at Ochsner Hospital in Baton Rouge. So I am all over the place. And, you know, timing wise, it's kind of hard to get appointments with me. So my schedule did not work very well for this either. So I really had to delve into it to figure out other ways to do my telemedicine practice. I actually came around the corner and started doing it more in the chronic care management mode. And once I started developing, teaching patients how to use the telemedicine platform, and I figured out how to make my schedule a little easier for those folks to book, later is where my urgent care visits started coming in. And that has been really a great thing, because when people need me now, they know they can get me through a telemedicine visit. Whether I'm in Baton Rouge or Hammond, they can kind of catch me, okay? But it was a market I had to develop, okay? So kind of think about that as you develop your own practice. Should you do urgent cares first? Do you think you'll be successful? Or do you need to go into the chronic care management first, okay? So I'm going to go through some urgent care visit types, because later we're in the next presentation 2 weeks from now, we're going to go through that chronic care management. So make sure you join us in 2 weeks. So this is actually a slide I have presented before. I will just have you scan down to the sick urgent visit tab. That's 1, 2, 3, 4 down. And, you know, this is just a general thing looking at cough, sore throats, congestion, allergies, fevers, headaches, asthma, and urinary tract infections. Those are kind of the big topic areas. And in that, with the treatment, we can often order medications. Since we have clinics, we can actually order testing through our centers and have patients come in after they've seen us or on another day if it's appropriate in their workup, okay? And what I'm going to go through now is just kind of expanding that. I actually am doing some urgent anxiety and depression type things. Now, remember, these are patients that I know, and you know, you all have your own practices. I know these patients. So doing that type of medicine, if you know someone, I think it's extremely appropriate to be able to do those types of things. We might have a little discomfort with having a brand new patient doing some of these things. So you kind of have to figure that out for yourself too. But asthma and cough, that's something that a lot of folks do. A fever workup, I'm comfortable doing a fever workup, especially if I feel like that patient is someone who I can follow up with very easily, have an opening in my clinic and that kind of thing. So we can have some close follow-up. Again, that comes down to your communication with your patient. Flu and COVID, oh my God, how many folks have we seen with COVID, and diagnose them? We could have them do the drive up and do the lab, but I actually did my visit through telemedicine. We could assess them physically and determine if they had respiratory difficulties and things like that. And I felt very comfortable with that. Headache workups, acute headaches, we can do that. Acute blood pressure, sometimes patients note that they have a high blood pressure and they want to get it addressed and they don't want to go to the emergency room. So this is something you can easily do. Muscle strains, you can easily do a great orthopedic type exam via telemedicine. So we'll go through some of that. Of course, pink eye, rashes, sore throats, stomach ache, diarrhea, constipation and nausea, and of course the old UTI. So let's kind of delve into some of these. Now I'm going to go through these kind of quickly. These are protocols, as I had said earlier, was developed by Dr. Asia Nikolic, who is down in New Orleans at Ochsner. And these, I think, are great references for anyone out there trying to make decisions about triage, because, in doing telemedicine, you have to be able to say, this is not appropriate for a telemedicine visit. That is your major job, I think, in trying to figure out how to manage someone. And sometimes you just have to pull the plug and say, look, I need you to come in. This is not going to work here. Or go to the emergency room. I think what I'm seeing here even rises to a higher level of care. So these protocols will be great for you to reference back to. But it's things that you would normally think of. For instance, with a bite, if you're seeing pus or they're having fever and things like that, you definitely would want them to be seen, either in your urgent care in your clinic or go to the emergency room to better manage it. You need cultures. You have to think about those things, and if you do, then you get them in. And I'm going to go through some of the red parts of this, because the red obviously on these is when you're sending them to the emergency room. With a bronchitis, you're obviously looking for cyanosis. You can see that around their lips, their fingertips. You can get them to check their fever and they can give you a history on that. Whether they're confused or lethargic, you would definitely want to be sending them in. And certainly the higher risk patients who have a lot of chronic medical illnesses, you would want them to do that. And if patients have already been on antibiotics and have failed therapy, you obviously need to get them seen. And of course, if they're short of breath or wheezing and having some respiratory difficulty, you would be having them move to a higher level of care. On constipation, if they're having abdominal pain and having some history of small bowel obstructions and things like that, they're vomiting and they can give you a history of not passing gas, they're having fever or a pretty severe weight loss or distension of their abdomen that you can see, then of course you'd want them to be seen now, in the emergency room. And if they have a lot of comorbidities, et cetera, you would certainly want to get them seen in the emergency room. But I have had a fair number of folks who are, they're presenting with chronic constipation and needing ways to deal with that. Of course, I'm trying to take a history on that to determine about, have they had a colonoscopy? Do they need to be checked and that kind of stuff? But you can easily manage that. For a cough, and then when I use this, it's more like not the super ill cough. It's the cough that's been going on forever. You do want to check if they have a fever and such as that, because that might push you towards the emergency room way. But being able to determine if it is the three cardinal reasons for a chronic cough is, nasal drip, asthma, or reflux, right? So you're trying to decide between all of those things. People are short of breath in all that mix. Obviously, you're going to be sending them on to a higher level of care, okay? Of course, in diarrhea, you're trying to assess for those same old things that we talked about on the others with the constipation, is if they're more acute, having bloody diarrhea, fevers, et cetera, you may want to get them seen. But in a patient with chronic diarrhea, this is something that you very easily could assess. One thing that I find, since I do a fair amount of GI work, there's there are a lot of folks who have diarrhea because of certain medications. So trying to take that accurate history on their medications that they use that could be inducing diarrhea that's chronic, try to make sure you document all that, and you can remove meds and alter meds and be able to help them that way. Eye complaints, you can see a lot with the eye with a telemedicine exam. So you can assess for this and you're looking basically if they have any severe symptoms like photophobia. That's a pretty good sign that maybe they need something higher level, some higher level of care. And of course, if they've had trauma, they need to have a better exam than what you can provide through your telemedicine visit. But a lot of other things you can definitely take care of through a telemed visit. We kind of talked about fever earlier. Of course, on this, you're wanting to look for signs of meningitis, double vision, neurologic type things. Of course, if they're having severe pain urinating, or of course, if they're having any kind of septic signs, you're wanting to send them to the emergency room. Headache, similar thing with the neck stiffness. We talked about the neurologic exam. I'm going to have a reference in here, a video reference from a neurologist who manages headache online all the time. She has a wonderful video that you can review and learn how to do a very complex neurologic exam for headaches. But headache is often with a telemedicine visit, you tend to do about the same thing that you would do in your office. Okay, everything. As I said in my previous lecture, 90% of your diagnosis for any problem generally is the history. And taking a good history is most of what you will make your decisions on. Your physical exam and your lab testing is the other 10% a lot of times. And so I think about it from the standpoint of I want to do the best history I've ever taken on a patient through a telemedicine visit. There they feel that they've been tended to because they've been able to tell me their entire story. But from there, I can then make any testing or follow-up examinations to be planned and in my office. So again, you have a practice of patients that you're caring for. It's people that you know. This is wonderful for those type folks because you've examined them probably, in the last 6 months or so. I spoke about high blood pressure. One of the things that I have to do with a lot of folks with high blood pressure is make sure they're taking their blood pressure right. So I have a slide that I'll show you later. It's basically, I send it to the patients, make sure they're doing all the steps in this. It's put out by the American Heart Association. It's a great flyer for people that you can take and send to your patients to make sure that they're doing the right thing. But if, people have a high, but, high blood pressure without any major symptoms or urgent type symptoms, you definitely can manage this through a telemedicine visit. The flu, this is similar to COVID. It's easily managed through a telemedicine visit. You can assess for septic type symptoms or respiratory type symptoms that would make you uncomfortable. And you can care for most influenza patients through this portal. Insomnia is something you may not think about from the forefront, but we do have patients who call in needing something for sleep. I try to really focus on some of the holistic methods of treating this because we don't like using a lot of narcotics or treating with narcotics through a telemedicine visit. I really am pretty adamant, except for cough syrups and stuff like that. We try not to use that type of medicine through a telemedicine visit. But the things that we worry about with insomnia, you're worried about any kind of psychological problem that might be going on, and you'd really want to assess them for that and make sure that none of that is more urgent than you would want to be dealing with through a telemedicine visit. A sore throat, when I first started doing some of the urgent care visits, it sometimes was a challenge to see their throat, but I've kind of gotten good at it. If I can get someone with a flashlight or for them to use their iPhone while they're doing their video through their computer or whatever, they can usually get a pretty good picture back there. All right. So I'm really happy. I have the program that we use for telemedicine. I'm able to snap photos so I can actually take pictures of physical exam components. And man, it's great to be able to see the tonsils on there, and I can stick that in my note. So if you get a telemedicine platform, it's great if you can find one with that. But it's with this, as far as going to an emergency room or not, obviously if they're having stridor or drooling, they can't swallow at all, et cetera, then you're needing to move them to a higher level of care, either in ER or in your own office. We talked a little bit about respiratory illnesses in general. This is just a broader discussion of differential diagnoses between viral illnesses, croup, pertussis, and things like that, with actual treatment recommendations on there. And then, of course, vomiting. If people are having severe intractable vomiting, they appear that they're getting dehydrated, can't keep any fluids down, et cetera, then they need to be moved to a higher level of care. But many folks can be evaluated and treated through a telemedicine platform. Before I do poll results, I just want to bring up a thought here. I want you to think of how you're doing practice now. How many times in your day do you get phone messages and you make clinical decisions on an acute issue through a phone message that may not have all of the information? And you currently are making decisions, I'm sure. Most people do. And they send out therapies based on that phone message. So in doing an acute care telemedicine practice, I'm able to get some of those folks in a visit with me. And I feel I'm thinking back to years ago when I didn't do that. And I'm thinking back now because I know now when I'm assessing people, I know that I'm treating them differently a lot of times than I would have based on that initial message I got. And I told my nurse, ask this patient to see me in a telemed visit. So I want you to think about that angle. I know I am doing better care than I used to with just addressing acute issues with a phone note. And, this is something that in the future, patients love this. They love being able to be seen because I think they have a general sense that they're probably being cared for better when they see a provider. Well, as you have more competition out there with more and more people giving access to people and more people wanting access through telemedicine, patients may start looking elsewhere for their care when they have an urgent need. So again, that's why I'm imploring people to look at telemedicine as a way for you to engage with your patients, care for them when they need it, how they need it, and keep them in your practice because you know them better than anyone else does. So, Danae, can you give us the poll results? All right, overwhelmingly, it looks like 80%, their top treatment is allergies, sinus problems, colds, and sore throat. Awesome. And a few headaches and, well, one headache and one hypertension. Okay, that's great. So overwhelmingly, I'm going to focus then on looking at that from when we talk about physical components. So thank you.
While we're paused, we do have a question in the chat.
Okay.
Someone asked, are there some rules that dictate billing for a separate visit if you end up seeing the patient in the office after doing a telemedicine visit? So if you refer them to come into the office.
Yeah, if you see them that day, that's all the same thing. You're not double billing for that. You just convert it from a telemed to an in-office visit. And my two favorite stories of that is I had one lady who had right upper quadrant pain. She had classic gallbladder symptoms. When I had her lay on her bed and she pressed in her right upper quadrant, her face made this face, you know what I mean? I said, you got to come in. So actually she had her gallbladder out later that night after I saw her, did a stat scan on her. And I had another one that it was right lower quadrant pain. Okay. And it was the same story. She didn't even know she was really hurting down there. Her main complaint, actually, she was having a cough. Okay. And she said it hurt kind of in her chest to cough. Well, when I did her exam, I mean, she was not short of breath or anything like that. I had her lay down on the bed, and when she pressed her right lower quadrant, it hurt her. I don't know why she was coughing. but she had a lot of pain, and it was an appendicitis. So she had her appendix out that night. Again, both of those patients I brought to my office. I confirmed my exam, and yeah, I needed to scan them, and they both got surgery. So again, you have to make the decision in your mind. That's your main job. Is this appropriate in this forum or this venue? And if not, you pull the plug and you either get them to yourself or somewhere else that they can get an evaluation. Okay, great question.
And
Thank you.
yeah, and I'd like to follow up on that, Dr. Hudspeth, if you don't mind. So if you do a visit and you evaluate the patient and determine they need to go to the emergency room, how do you bill that visit?
On that one, it really depends upon the time and the complexity of things that I went through and did and made evaluations on. If it's kind of clear from the get-go, I'm not going to bill for that. No. If I realize straight off the get-go, if it's a lot of decision making, maybe reviewing charts, that kind of stuff, then I would consider that. But the vast majority of them, I don't. I just, if you didn't provide any value and didn't really help them much in the decision making, you shouldn't do that. Okay. Any other questions?
None at this time, thanks.
All right, let's move on. See if I can get my screen to go here. There we go. All right, urgent care physical exams. So this was actually in one of my last presentations, just going through some general things, just not disease specific. Constitutionally, you can tell if the patient looks like they're in distress or not, okay? Whether they're diaphoretic or anything like that. On their EENT exam, it's pretty easy to go through the eyes. You can see that very well. If I'm dealing with a sinus complaint, I have them tap over their sinus areas to make sure, if they're having pain there. I look for nasal flaring and that kind of stuff. I ask them to breathe through their nose for me, see if they're congested. If they can't breathe through their nose, they're congested, okay? Then looking at their throat, you can get a pretty good exam on the throat for most folks. They may need some help from someone else to be able to assess that tonsillar area, but that you can get that most of the time. Another thing that I do is I ask them to feel in their neck area. If they have a fairly sizable lymph node, they can tell you, I feel a knot there, or they're tender there. And those are things that you can document, as far as your exam goes. Looking at their pulmonary, a trick is you can get them to cross their arms and just watch them breathe. It's more of a visual than the chest sometimes. So you can count their respirations. I ask them to exhale somewhat quickly. If you're listening good, you can hear a wheeze on people sometimes doing that. You can obviously see if that deep inhalation and exhalation triggers a cough. Many times when people have some of the more bronchitic and wheezy type problems, that process will trigger their cough, which can go on and on. Sometimes they keep going with it. And you can also see if there's any distress, going back to the nasal flaring and seeing if they appear short of breath with that. On the abdomen exam, on that, you can't auscultate their abdomen, but they can press on their belly, or an attendant with them can. And just like you do in the office, you divide it up into 4 quadrants, teach them that around the belly button. You can tell them how, I want you to go in the right upper side, left upper side, and they can slowly press in. Obviously, you're looking for patients' response to that. Did their face grimace? Did they say they had pain? That's a pretty good sign there. You can also hold the phone at the side of their abdomen, see if they're distended. I try to document any surgical marks, because that can lead you to a lot of things, right? So the abdominal exam, you can do a lot on that. On the skin, now in skin lesions, video is not always the best thing. I love a photo. So I actually ask folks to sometimes send me a photo if the video connection is not the best. Another thing that hampers me, sometimes it's hard for them to hold it still. And that tends to make it a little jittery for me to be able to see something fine. So asking them to send you a photo of that's a big help. But man, skin exam, you can do almost as good as you can in the office if you've got good light and a good detailed photo. On the musculoskeletal exam, just about any joint, you can do the range of motion exam on that, okay, and determine or show what they may have limitations with. You can obviously look for swelling and have them palpate their joints, show you where they hurt, and be able to document that. One I love to do is when I have a low back exam. Again, I tell you, I'm able to snap my photos. So I actually have them position the phone. I make them bend over and touch their toes. I take a photo of that. I have whoever's with them do a straight leg test. I love being able to show that. They were able to even get it up, in a 90-degree angle, and did that and document if they had any symptoms with that. So of course, my history is important there, talking about incontinence or numbness or weakness and those kinds of things. In the neurologic exam, much of the cranial nerves many of the cranial nerves can be examined while you're doing a telemedicine visit. You can do rapid alternating movements. You can evaluate their gait with that. And then of course, psychiatric, it's pretty much the same as being in person. So this little reference right here, this is a great reference to be able to go through all of the physical exam components that I think are really helpful to people when they're starting their practice. So it's just suggestions for you. And this is one you can just do a one-page printout and be able to develop your templates if you have an EMR that allows you to develop normal and abnormal findings on your exam. Vital signs, man, vital signs are somewhat of a bear because, it's best if you have your staff get them to get their vitals before you get in the visit. Because, when you're pushed with time, if you're sitting waiting on vital signs, it's a little bit difficult. So you have to work on your pre-visit workflow, which we had in a previous lecture. So you can look at that. But if you can get those vital signs, that's pretty important. And we're working very hard to be able to make sure we get that on every visit right now. But if you have troubles with being able to get them to get an accurate one, it's all over the table, then you might have to get them to bring their cuff to you and validate it. We are trying now to validate or get people to bring their cuffs and once a year validate their blood pressure cuff, especially if we're following them for hypertension through our chronic care program, or if we're writing some medications that may raise their pressure. We want to be able to document that for every visit. Okay. This is the little handout from the American Heart Association. I send this to patients just so that they know all of the 7 simple tips to get an accurate blood pressure reading for me. The skin, we talked about that earlier. There are so many things that you can look at with the skin. It's almost like being in the office. We talked about head, eyes, ears, nose, and throat. On this one, you can get a pretty good thing. Right now, you can't get the ears. There are some devices that patients can purchase. Of course, they're fairly expensive, and so that's not mainstream yet. But it is coming where patients will have some tools that you will be able to see their eardrums and a more detailed throat exam and all that kind of stuff. And you'll be able to auscultate their heart and their lungs. So more people will get that over time too. The neck, we talked about palpation of these glands here and documenting whether they hurt or not. Of course, range of motion of the neck. You can do all of those types of things. You can see how they swallow. And sometimes you can even see if they have a bounding pulse in their neck, okay? On the lungs, we talked about this, about the breathing deeply and exhaling and seeing if you can hear anything there. And of course, respiratory rate and the labor of their breathing is very important and can give you a lot of clues. The heart, I can get most people to feel a pulse and then count out loud. And while they're counting out loud with each beat, then I can calculate their heart rate. So I do that sometimes if they don't have a monitor at home to be able to do that for me. and that'll give me some clues too. The belly, we talked extensively about the belly. I love that exam. Extremities, you can do, fingernails, looking for cyanosis and those kinds of things. As far as like doing an exam to look for a Tinel sign or a Phelan sign, those are things that you can instruct people to do if they're having, carpal tunnel syndrome type problems. Of course, if it's an ankle, you can see whether they have swelling or not, whether they have a hematoma. You can see their eversion, inversion of their ankle. You can show if they can bear weight, and actually they can feel and show you exactly where it hurts the most. So neurologic, I'm going to send you to that reference of the lady doing the headache and the neurologic exam there. There's a lot that you can do on the neurologic exam. And then I'll throw in social determinants of health. It's not a physical component, but oh my gosh, that is becoming a more important thing for us to make sure that we assess and document, because so much of these determinants determine how much or how well we can treat our patients in the telemedicine field. So I'll just go through these real quickly. This is one that's the general physical exam. It's a video that you can reference and see. And I'm going to click through these, and I don't want them to start playing. So this is how to conduct an ear, nose, and throat exam via telemedicine. Cardiopulmonary exam via telemedicine. Respiratory exam via telemedicine. An abdominal exam via telemedicine. Musculoskeletal exam. And this is the neurologic exam that I'll tell you about, like the headache exam. That's a great one. Dermatologic exam. And each one of these are probably 20 minutes or so. And you really need to spend some time just looking at each one of them. So you develop your own rhythm and pace of how you will do your exams online. I included this one. This is looking at a pain exam. How to conduct a telemedicine physical exam looking for pain clues. So I love this because so much of what we do is in an urgent world is pain. We're trying to alleviate pain. And this will help you on looking for all of those clues. The psychiatric field for this, I believe in the not too distant future, there will be more psychiatric visits done through telemedicine than in an office. Psychiatric problems lend themselves so much to telemedicine that I think it's going to be the default way that people will be cared for, both because of ease of use, comfort. Think about folks who are having some depressive symptoms, et cetera. They may feel more comfortable in their own environment talking about their issues. Another thing that is great with telemedicine, you're able to see their environment. So not only with this type of problem, anxiety, depression, things like that, but seeing their own environment, say they're there for a bronchitis problem. Well, you're seeing that they have cats that are coming on the screen, because people have cats sometimes crawl on the computers while I'm doing their exams. Maybe they have allergies from that stuff. So think about that is an additional thing that you can gain in a telemedicine visit that you just can't gain in your own office. I went through and on these, the anxiety inventory, depression inventory, hopelessness scale, and the HAM-D, I went in and actually made like handouts for you to be able to use yourself in doing some of these psychological evaluations. I wanted to be able to have a reference where everyone would be able to use these and document things appropriately in their own records. The PHQ-9 and all the ones down below there, these are actually online scales. So they're really easy to use, guys. I'd invite you to go and look at those for your regular practice, not just for your telemedicine practice. But it's a great way for you to be able to put a score, not only to help your diagnostic criteria for treating psychological diseases online, but it's a great reference for you to go back and compare in the future when you do your follow-up with them, being able to show that you had some improvement. okay? So I will ask the team to post those other forms because they're all Word documents on our site also. So as far as documentation, this is really strictly here for reference only. This first part, this intro part, is what's required on every single telemedicine note you do, whether it's urgent care, chronic care, whatever. This verbiage needs to be at the top of every note. So I put it on a separate slide. And these, where the 3 asterisks are, my EMR uses that as a jump point. So I can jump from one asterisk to the next to fill in the blank, basically, okay? So you can fill in those blanks for your own. This is for a generic telemedicine template for people who use EMRs with data links. So for instance, I use Epic in my practice, and these data links actually pull data from other places in the chart, like past medical history, review of systems if patients have filled in that online, and that kind of stuff. So it really helps in your documentation if you're using that platform. And this is just more of the same. Again, I told you that this would be a reference tool for you in the future, not just a presentation tool for today. So the last thing I want to show you is listing your practice online. There are so many groups now that you can actually get started with to list your practice online. And I just wanted to kind of go through one simple thought with you. There's one called ZocDoc. I don't have any preference for that. I just picked that one. Okay, guys. There are a lot of them out there that you can choose from, but this one has something called APIs. If you look, you see that first verbiage there, make it easier for patients to reach your clients. Okay, now clients, that would be providers in your practice. An API is a tool that they're able to interface many people's scheduling system with an online interface. So it allows a patient to be able to go on your website and schedule an appointment directly in your scheduling system, which is pretty cool. Okay, so that service is out there, and I did want to just go through this little video. Let me see if I can play it. Tell me if you can't hear it, Danae.
Every time a patient books a ZocDoc video service appointment with you on ZocDoc, it gets added to your ZocDoc calendar. And you'll also receive email and text message reminders. Just click the link to get started. You may need to log in first. This will take you to your virtual waiting room. Your patient also receives automated emails and text reminders from ZocDoc with instructions on how to join their video visit. They'll be in the waiting room at the time of the appointment. Just click Start Video Visit next to your patient's name. If your patient requires a follow-up, remind them that they can easily book another appointment with you once the video visit is over, since they are already on ZocDoc. You can also use ZocDoc Video Service on your smartphone and tablet's browser. There's no need to download an app. It's that easy. Try ZocDoc Video Service today.
All right, so ZocDoc is not the only one out there that does that. Many of them do it. I just wanted to show you how easy it could be for you to develop your own program for your patients. Oops. And I'm trying to get back into my program here. Apologize. It brought me to the main website. Hold on just a second. There we go. And that really ends the presentation part of this. We have a lot of resources that we keep on all of the PowerPoints. As Danae told you, we will not only be posting the videos, but we will also be posting the PowerPoints so that you can go back. And I really feel like of all of them, this one's going to be the biggest repository for you to be able to figure out how to do your physical exams and how to manage various things that you're going to care for. Contact information, you can contact Danae at wellahead@la.gov. You can see all of the videos at the next link on the telehealth link. So let's open it for questions here.
I don't see any in the Q&A right now, so we'll give it a minute.
You know, in starting my own practice, I remember how I was nervous about being able to, or feeling like I would be able to do a good exam on patients. And again, I go back to the 90% rule, that 90% of your history, 90% of your diagnosis should come from your history. That's ever more important in the telemedicine world. And being able to pair up many of the physical things that you can do, you're going to be able to do a great job of caring for your patients that you already know and care for. Did we have a question?
Yes, so someone is asking if all of those exam resources that you gave will be on our Walpin website. And I think you can send all those to us. So we will put those with the PowerPoint on the webpage.
You're talking about the psychological exams?
But I assume so. Also, the PowerPoint itself will be saved there, so you'll be able to go in and look at it. And then we'll make sure that the videos are viewable. We may have to link those out separately. And then the psychological documents that you mentioned.
Yeah, I'll send all of those and so that they can be posted too.
Yeah, she's saying the physical exam mainly, all of those protocols and things.
Yes, all of that is part of this PowerPoint, so it will be on there. It'll be in the PowerPoint.
Yes, because the flow charts, I'm sure, will be very helpful to go back and look through.
Yes, like I said, I designed this one to be almost more of a reference tool rather than a presentation tool. So I just know that's probably where most people have their angst about doing telemedicine, is getting a comfort level with being able to make an accurate assessment. I mean, and that's very appropriate. I'm telling you, you will be able to. You can always say, I'm not comfortable with this presentation and this illness. Come see me. You know, you can always do that. So I'll make one last pitch for 2 weeks from now. We're going to be working on chronic problem management, which probably a lot of you do a ton of in your practice. And maybe like me originally, I never thought about doing chronic care management. But if you remember that slide that I showed you where everything is going up like this in the telemedicine world, preventative care and chronic care are going to be the bulk of what you're going to see in telemedicine. It's urgent care is going to be a huge piece too, but those two pieces are going to be massive.
So someone is asking if there's a chance of getting LBME to approve CME credits for these conferences. I don't know, that's a little outside of my scope. I'm not sure what qualifies.
Up to you. I think you have to apply for that and have that signed off by some educational entities, but I fully feel like all of these probably should qualify for that. I don't know how you go back and do that, but you know, what I'm providing here for people is stuff that I wish I had access to when I first started. I'm hopeful that some of the pitfalls that I've had will be smoothed out for you as you look at all of these. And I just can't thank Danae and Tracy enough for them providing this and getting this arranged for me to be a big part of it. So thank you.
All right, well, we are at time. And not seeing any other questions, we'll go ahead and we'll wrap up for today. So thanks everyone who joined us today. Again, everything's going to be on our walpen.org/telehealth website. You can also submit questions through there. There's a form at the bottom of that webpage. March 25th at the same time, Thursday at 5:30 is our next session. And again, we'll be talking about chronic care. And then as you exit, you should get a pop-up in your internet browser that'll ask you, it'll be one survey question that'll ask you about any future topics that you want to cover in any of these sessions. We do have a few topics that are still open. We're still trying to decide where the need is to determine what we're going to cover. So if you have thoughts on that, please go ahead and answer that one survey question. And as always, feel free to reach out to us at any time with any questions. And thanks and have a great night.